Hello class, and welcome to week 10, Introduction to Psychology. My name is Dr. Neil Soggie, and today we're going to be taking a look at psychological disorders. And I'd like to start off with a little joke. So there was a psychologist's office, and the receptionist rings back to the psychologist and says, "Doctor, there is a client in here that thinks that he's invisible." And the psychologist replies to the receptionist, "Well, tell him I can't see him right now." Ha ha. Okay, let's get on. We're going to be taking a look today at clinical psychology and dealing with psychological disorders. And we're going to narrow down, for the most part, just looking at some common mood disorders, because there's such a huge topic. It would literally take years to cover everything. But before we narrow it down, I want to kind of start off with giving you a little bit of experience about what we call the mini mental status exam, and how you can use your whole body and your whole experience in evaluating a client. This is something that therapists will do as they meet a client, and it just is a good structured way of getting to have a sense of where to look for different types of disorders within a client. So I'm just going to kind of start off with that. Now, you can really have this in larger parts or smaller parts, and I'm going to kind of just walk through all of the major parts of the neurological side of it, not just the psychological disorder side. And the reason why I'm going to do that is really to give you a sense of everything that's there. So in a typical neurological exam, you typically have 6 parts. You'd have, first off, your mental status part, and your cranial nerves part, and your motor exam part, examination of sensory nerves, of exam of coordination, and exam of reflex. But maybe I'll just narrow down to the mental status part. Now, oftentimes, a full examination cannot be done in that order, depending upon the nature of the patient. And so you need to kind of keep in mind that you should cover all these areas if you're doing something thorough in a biological, psychological sense. But it's important to at least keep good records of what you're doing and the order that you normally do things in, so that you don't miss anything. So let's just kind of start off with the mental status side of things. And it's really kind of divided arbitrarily into 2 subsections. So you can think of it in terms of a psychiatric mental status exam and a neurological mental status exam. So remember that this is really fairly arbitrary, because we all know that diseases of the nervous system are associated with the brain, no matter what we call them. But for the sake of organization and structure, we'll divide them into these different groups, just so you have a bit of a flavor of what kind of goes on in the clinical setting. So with the psychiatric mental status exam, I'll focus primarily on that, but I do want to kind of point out some basic things that you should look for with the psychiatric examination when done by a non-psychiatrist. So, and really this is done to come away with some idea of the patient's, first off, thought content. And when I mean thought content, I mean that's the code, which is an internal code used to communicate with itself. And really, language is our window into that code. So when we look at this, we want to look at what is normal about thought content. So, for example, if someone thinks about funerals 95% of the time, that's not normal thought content. And then there's also thought process disorders. And this is if there's no logical connection between the thoughts. So if you can't understand what the person is saying, then you can assume it's them, not you. So those are just some basic tricks that you can use in a clinical practice. So a thought process disorder would be, for example, someone talking about, how's your day going? They would go, oh yeah, my day was going good. Do you know that there is quantum physics on this side of the moon, and that, oh, my cat was drinking some water the other day, and then, oh, my boat is just beautiful. You got to see my boat. That sort of thing would be a thought process disorder. Okay? And then we also look at, so we're looking at thought content and thought process. Those are the two key things that we look for. Then we also look for mood. And really, if you think of it, mood is the feeling of the person. But there's another side to it. There's something we call affect. And affect you can think of as the external appearance of that mood. So, if someone is happy, they should look happy, right? If there is a dissociation then between the mood and affect, then we're looking normally at a neurological disorder. So there's some neurological disorders that can cause mood affect dissociation. So for example, multiple sclerosis causes a mood affect dissociation. Some psychiatric disorders also produce this. So for example, schizophrenia causes affect mood dissociations. So when you see this type of dissociation, you know there is something wrong. And it needs to be looked at further. It's an aha moment. I see a dissociation between mood and affect. And really to understand the person's mood, just simply reflect upon how you feel after you walk out of the interview, because our bodies are ingenious at detecting mood. And it's not something that we cognitively reflect upon. So we ask them, how are you feeling? And then you reflect upon how are they making you feel. And you can also look at their face, their affect. So to identify an affect mood disorder, simply compare what they look like with how you feel, or how they make you feel. If there is an incongruence between the two, then you can say, aha, there is a mood affect disassociation. And if you do this, you've done a pretty good psychiatric mental status, because you've already caught a huge part of what it means to be looking for the disorders. So there's lots of other parts. And so we'll take a look at the neurological mental status exam now. And there's some parts to it. But, you just kind of need to remember that you need to kind of catch all of these parts. So let's go through some of them. So the first thing is the level of consciousness. So on a spectrum, are they alert or are they comatose? If the person is okay and alert, then you can go on to the second part, which is language. And if you notice, all the things we've been talking about in this course, all the different parts, those are parts that build towards understanding mental disorders. So then we go to language, okay? And any language can be used. So If there is language, that's a good sign. Then you can go into the aspects, the third aspect, which is memory. So remember, you can only test someone if they have language. And if there is a reasonable memory, then you can test the visual spatial skills. So ask them to define what is up, what is down, what is right, what is left, what is part of you, and what is extrapersonal, what is me and what is not me. If they can come away with that, then you've done a pretty good job. So let's test some of these and just kind of look in on a more concise level what I'm talking about here. So the first one, level of consciousness. Are they alert to attentive? Inattention is the inability to maintain a coherent focus. This is known as a confusional state. If this inattention has with it hyperactivity of the autonomic nervous system, like tachycardia, shaking, dilated pupils, tremors, maybe even hallucinations, this is typically called an agitated confusional state, also known as delirium. If they are in a confusional state, you cannot tell that from casual conversation. So you should test for a continuous stream of controlled thought. And an example of this is the Serial 7 test, which is saying something like this. I want you to start at 100 and subtract 7. And then another 7. And keep doing that until I'm stopped. And a confused person will do this. 93, 83, 73, 63, or something like that. But the problem with that is that sometimes people are just bad at math. So sometimes a better one is the 1-tap, 2-tap test, where you tell the person that when I tap once on the table, you tap twice on the table. And when I tap twice, you don't tap. And a confused person cannot focus well enough in order to do that. So you can kind of try that with a friend sometime. And if nothing else, this kind of test, the 1-tap, 2-tap test, will help you feel more awake. Now, as far as the confusional state goes and this whole level of consciousness, confusion really is typically caused by biological encephalopathy of some kind. So some kind of brain infection or disruption of the chemicals in the brain. So it's probably good in that case, if a person is in a confusional state, to send them to a general practitioner doctor and look at things like electrolytes or their liver function test, or maybe possible drugs. So that's part of the referral process. Psychologists can't cover everything, so we need to know who we can refer a person to as well. And if that's okay, then you go on to the next part in language. So the language test. Now remember that language is almost exclusively in the left hemisphere. So if you're right-handed, you have our left hemisphere dominance of language. So a bit of a side note there, and I think we've talked about this a little bit. If you have someone who has had a left hemisphere stroke, they will have their right hand will experience paralysis, and they will not be able to talk. And if you go next door to the person with the right hemisphere stroke, maybe their left hand is paralyzed, but they'll be able to answer you, and they'll be able to say, oh yeah, I'm doing fine. So you need to kind of remember that the left side of the brain is the language side of the brain. Now, you can kind of think of it this way. There are two people in your head. One talks and one doesn't. the right and the left hemispheres. But you only know what is going on in the left hemisphere if the left hemisphere is willing and able to talk. Now, some people will say that the right hemisphere is creativity and the left is math. That's not really true. The brain's a lot more complicated than that, but you get the picture. So in doing this test, you're looking at language. Is language fluent or not? And does it sound like language? If it's not real language, but sounds like it is a language, then we call that fluent aphasia. And sometimes this is confused with a foreign language. Another problem can be non-fluent aphasia, in which a person sounds like this. Crap! The shit! And if you notice there's some muffled sounds and then some curse words come out perfectly clear. And the reason for that is that some words have an emotional meaning, and so they're stored in different parts of the brain from regular language. So you need to kind of remember that. Swear words aren't real language. And that's true neurologically. So we look and see if there is fluent or non-fluent aphasia, or no aphasia at all. And then we make our second decision. Is there normal or abnormal comprehension? Yes or no? So we start off normally by putting our hands in our pockets so that we don't give away any clues. And then we ask some questions. Who's the Prime Minister of Canada? Who's the President of the United States? And even aphasics that can't speak can nod yes or no to this. So if I said, is Donald Trump the President of the United States, they could nod yes to that. And then see if they can repeat this phrase. No ifs, ands, or buts. And it's a good, simple way of seeing if someone is aphasic, because aphasics typically can't say that phrase. So you end up with these three areas to evaluate language. Is it normal language? If so, great, then we probably don't have any problems with the left hemisphere. Or is there fluent or non-fluent aphasia? Is there normal or abnormal comprehension? And is there repeat or no repeat with that kind of language? So you can then clarify for referral. So you can say, Mr. Smith has a fluent aphasia with non-comprehension but bad repetition. And you really don't need to do any more if you're going to give a referral to like a neurologist or something for something like that. So, what if language is okay? Then we can go on to memory. And this is core because it identifies things like dementia. So, 3 types of memory that we can think of in the clinical setting. The immediate recall, intermediate recall, so like 10 minutes or later, and long-term recall, which is everything else. So we've already tested immediate memory with the other questions that we've asked, and the test of attention ability requires obviously some immediate recall, so we're covered there. So we likely can't test long-term memory unless we know something about the person. But what we can do is, ask them something about, say, for example, where were they on 9/11? That might be able to test that as well. And then we can also, as far as intermediate recall, we can tell a story and ask them to recall it 10 minutes later. And what I typically use is this. Tom and Bill went fishing. Bill caught 3 black bass. And then I have that repeat that back to me, and then 10 minutes through into the conversation, I will ask them to repeat that back. Tom and Bill went fishing. Bill caught 3 black bass. Good intermediate recall. Okay. Then we can look at the video spatial skills. And here we just give them a piece of paper and have them write their names, their address, and a sentence about the weather. Maybe draw a circle that is like the face of a clock, and get them to put the hands at 2:30. And then we might do a few things to test for extrapersonal and spatial knowledge. Okay, we've done all of that. That's a pretty good basic psychiatric mental status exam. Now, there's some other things that you can do in there, like, for example, when you shake the person's hand. Now, we're not going to be doing that during the coronavirus, but if you greet someone at the door and shake their hand, you can be checking for good tone, bulk, and power in their hand, because it doesn't matter how much someone exercises, their hands aren't going to bulk up. But if there's any problems neurologically, it's typically going to show itself in the hands. Is their handshake okay? Then a test for coordination is just watching how they walk as they come into the room. That's a good test for coordination. You can also just ask them in the conversation, how did you find it? The office, was your trip here okay? Can you tell me a little bit about that? And if they showed up on time, and they can tell you a little story about how they showed up at the office, they had to take 3 buses and then walk 6 blocks to get to your office. Well, that shows, and they got there on time. Well, that shows that they have good orientation of time, space, and person. They've identified themselves. Then you have all of that information as well. So there's lots of things that you can do in an initial interview that are very subtle, and some a little more obvious, in order to rule out numerous things. So that just gives you a little bit of a picture of the kinds of things that you would look for in a clinical setting. Now, let's go on and explore a little bit about how modern clinical psychology looks at mental disorders, and some of the ways we think about what constitutes a mental disorder, and some of the characteristics that kind of cut across mental disorders. And then we'll maybe take a look at narrowing in on some mood disorders, some very common ones like anxiety, depression, bipolar. So, we start off with the most fundamental question in clinical psychology. What is abnormality? Where do you draw the line between normal, healthy, typical behavior and what we might call abnormal, atypical, deviant, unhealthy, maladaptive mental problems? We tend to have an intuitive sense of what we mean by abnormality, but in science and clinical practice, you need to be much more precise than that. For example, we don't have blood tests where we can say, aha, this person is schizophrenic or whatever. So we need to look at a set of symptoms in order to determine if they meet the criteria for different defined disorders. Because remember, there's no biological test for mental disorders right now. And instead, we have a set of behavioral criteria for how to diagnose different mental disorders. And the authoritative text that we have for defining mental disorders is the Diagnostic and Statistical Manual, what we know as the DSM. And right now we're on the DSM-5. When I first started, years and years ago. We were way back on the DSM-3. So things have changed a lot since then. The way that we diagnose has changed a lot. The criterion for the disorders has changed to some extent. And some disorders have even disappeared from the list. So what do I mean by behavioral criteria? That's really a set of symptoms that the person reports to you about how they feel, how they think, and a set of observations that you collect about their behavior, and we try to look at what is typical and what is atypical. So we take that set of symptoms that the person has shown or reports and compare that to an existing list of criteria in the DSM and make a judgment. And so the things that we should also be mindful of is that it's oftentimes fairly easy to notice this. First off, there's social norms. Whether you get labeled as having mental disorders or a problem really depends very heavily on what your social or cultural norms are. So for example, a woman wearing a veil in a Muslim community or culture would be seen as very typical or even prescribed behavior, whereas a woman wearing a veil in a non-Muslim culture, especially until fairly recently, would often be looked at as very atypical or abnormal. So you kind of need to keep in mind cultural influences in this as well. The second kind of thing that gets that really influences whether something is called normal or abnormal is certain characteristics of the target person. So you need to kind of keep in mind that cultural expectations, for example, for crying, there's different gender stereotypes. It's okay for a woman to cry. It's not okay for a man to cry. So a man crying can be seen as unusual. And the third thing is that can really influence whether something is labeled abnormal or not is the context. So, for example, someone, you might think they're paranoid. If you're paranoid and hypervigilant, looking for threat, well, that's one thing if you're in Vancouver. It's another thing if you're in the middle of a war zone in Syria, for example, or wherever. So it can be normal or it can be abnormal based upon the context. So in the field of clinical psychology, we have a number of different ways, kind of heuristics, that we use for labeling things as normal or unhealthy or troubling. And three of these characteristics are what we often call the 3 Ds. So think in terms of distress, of dysfunction, and deviance. So behaviors that cause the individual or others significant distress often get labeled as abnormal or unhealthy. Depression is a prime example. It's a miserable state of being. You're unhappy, you're sad, you feel like there is not ever going to be the possibility of joy in your life again. There's distress in that situation. But sometimes it can be that the person themselves are fine, but they're causing distress in others. So an example of this is something called antisocial personality disorder, where the individual has no regard for the rights of other people, has no hesitation to steal from or hurt people, has no empathy or sympathy for other people's feelings, and so can inflict a lot of harm on others and has absolutely no distress over this whatsoever. But this behavior causes other people distress. And that's one of the reasons why that's labeled as abnormal behavior or a mental health problem. A third general criterion is dysfunction. If a set of behaviors prevents the person from functioning in daily life, then it might be labeled as abnormal or might end up being labeled as a mental health problem. Again, using depression as a good example. People who are depressed often become completely non-functional. They can't get up. They can't get out of bed. They can't go to class. They can't go to work. They can't interact with other friends. They withdraw. They become totally isolated socially. So they might lose their job. They might flunk out of school. And there's a complete decline in their functioning. It's dysfunctional. And then finally, there is deviance. The behaviors or feelings are highly unusual. And this is probably the most controversial of the three because it's weighted. It's so heavily influenced by social norms. What's deviant in one culture is not deviant in another culture. But if a set of behaviors is completely unacceptable in a culture, highly unusual, they're more likely to end up getting labeled as abnormal. So we just kind of need to keep that in mind. So a little bit about the Diagnostic and Statistical Manual. Starting off, clinical psychology and psychiatry in the United States, the Diagnostic and Statistical Manual was used as a way of defining types of disorders. And the intention there was so that we could start to move towards an understanding of these disorders. We'd have a way of defining them so we could research them and so that we could develop treatments for them. It's hard to know if a treatment works if we don't have a good definition of the disorder. Now, early on in the 1950s and 60s, this system was very highly subjective and was strongly based on Freudian theory. But there slowly became a move away from looking at Freudian insights to a cluster of observable symptoms. So when we get to the DSM-3 and the DSM-4 and now in the DSM-5, these clusters of symptoms really kind of define what is going on with the person. Now, in the DSM-3 and the DSM-4, what you had was a 5-axis system where you looked at 5 different areas of life and functioning in order to give a diagnosis. However, there became a trend in clinical psychology where it felt like that 5-axis system was beginning to dehumanize people too much. I think personally that it was very good because it reminded us that there are lots of different aspects of a person that go into it. But be that as it may, when we came to the 5th edition, we did away with the 5-axis system and went to just simply writing a series of sentences to describe what is going on with the person and how they fit with the cluster of symptoms that are laid out in the DSM. So that's just a little bit as far as diagnosis goes. So let's narrow in a little bit now and talk about mood disorders, because mood disorders are one of those most common features, and we're going to look at primarily depression. But I want you to keep in mind that depression and anxiety are kissing cousins. They're very closely related. So if you have depression, there's a good chance you also experience anxiety. If you have anxiety, there's a good chance you experience depression. And neurologically, they're very close as well. So you can kind of think in terms of, I don't want to leave out people that experience anxiety. Think of depression as something closely related to that. So in terms of prevalence, just looking at mood disorders, as many as 1 in 4 women will have an episode of serious depression at some time in their life. And about 13% of men will have an episode of serious depression in their lives as well. Although honestly, based upon my own clinical practice, the number's probably a lot higher. We just don't see a lot of men because culturally, it's more acceptable for a man to just go drink in the bar and numb their feelings rather than seek out help. So these are extremely common disorders that a lot of people experience. And the college years are a time when the first onset of depression is very common, as well as other disorders like bipolar disorder, manic depression. In the late adolescence, early 20s is often when people will experience this. So I want to start off by talking first off about unipolar depression. And what that means is there's a downward dip, and that's different from bipolar. Bipolar disorders, it's where a person cycles between depression and mania. Unipolar depression, though, is simply going down into those dark depths and kind of feeling like you cannot experience any kind of joy. And so one of the first criteria in the Diagnostic and Statistical Manual for major depression is that the individual has to either show sadness or diminished interest or pleasure in their usual activities. And we often refer to this as hedonia. So instead of being a hedonist, you're an anhedonist. You're not seeking pleasure. You basically are neutral to things that would normally give you pleasure. So you have to have one or the other of these to sort to get past that first criterion. So you might say that you feel sad or blue, or actually say, I feel depressed. Now, some people feel those feelings very strongly. Other people don't really feel so sad or blue. But what they'll say is that nothing interests them anymore. It's like the emotion has been sucked out of their life altogether. They don't have any fun doing the activities that they used to do before. They don't want to hang out with their friends. They just don't care about eating or doing anything. They just feel nothing. Nothing feels good anymore. And then the individual has to have at least four of the symptoms in addition to this sadness or anhedonia. First, they can show significant weight or appetite change. So you may completely lose your interest in eating and lose a lot of weight, or some people go on eating binges. So you might gain or lose a significant amount of weight over a short period of time. There are sleep disturbances, insomnia, which is having trouble sleeping, or hypersomnia, which is sleeping all the time. There's a particular form of insomnia that's especially likely in depression, where you can go to sleep at night, but then you wake up at around 3 or 4 in the morning every night and you can't go back to sleep at all. You're just up for the rest of the night. But other people want to sleep all day long. And so it may be that they sleep 20 hours or 22 hours out of a 24-hour day. And then the third criterion is psychomotor retardation or agitation. The retardation is much more common, and what this means is that sort of everything about the person's movements just really slows down. They'll walk slower, their reaction times are slower. They just move slower, and you can really see that they're depressed. They look fatigued. They describe themselves as feeling tired and fatigued. They have no energy. Or agitation, where there's that nervous energy that kind of goes. Number 5 is feelings of worthlessness or excessive guilt. They may feel as though everything is their fault. And the guilt feelings or sense of worthlessness can even really get psychotic, where there's a loss with being in touch with reality. Now that's an extreme. That doesn't normally happen in depression, but it can. When a person loses touch with reality when they're depressed, it typically has really depressing themes. They may believe that they are Satan, or that they are literally living in hell, and that they need to commit suicide in order to save the world or something. Overall, the feelings of worthlessness and guilt just are overwhelming for a person. Number 6 is diminished ability to concentrate, or an indecisiveness. When you're depressed, it's really hard to pay attention. You'll read a passage over and over again, and you just can't process it at all. You can't concentrate on a lecture. It's difficult to take notes. And then there's suicidal ideation or behavior. And what it means is that you think about committing suicide. You think about dying. And a subset of people actually take action to try to hurt themselves or kill themselves. Now, it should be said that suicidal thoughts and behaviors don't only happen in depression. They actually happen in all types of psychopathology, but they are particularly common in depression. So you have to have at least 1 to 4 of those symptoms, plus sadness or anhedonia. And these symptoms, it can't just be a bad day that they're having. These symptoms have to be present persistently for at least 2 weeks to get a diagnosis. So there you have a bit of a sense that there is a minimum criterion of time as well in the Diagnostic and Statistical Manual. So that gives you a little bit of an example of what depression looks like. Now, in terms of, and that would be unipolar depression, but I also mentioned that there is bipolar disorders. And bipolar disorders involve symptoms where you have periods of depression, but then you also have distinct periods of the opposite of depression, what is called mania. So the person cycles back and forth between debilitating depression and manic episodes. So let me describe manic episodes to you. So the first criterion is that instead of feeling down, blue, or depressed, the person has an abnormally and persistently elevated, expansive, or irritable mood that isn't just, again, isn't just a good day because you won a prize, or you got an A, or you got a promotion, or you have some money in the bank. This is unusually positive, expansive mood for at least 1 week persistently. And then the person has to have 3 or more of the following symptoms. First, inflated self-esteem or grandiosity. The individual may feel as though they are the smartest person in the world, or the most creative or insightful or powerful person in the world. They can rule the world. So there is no problem with self-esteem, thank you very much. Now, if you can't keep up with this person, then it's your fault, it's not their fault. Their talk will be pressured. They'll talk really, really fast. They'll be really excited. Their thoughts will be racing. They will have endless amounts of energy. They are highly distractible. And then there's this increase in this, what the DSM calls this goal-directed activity. And out of their grandiosity will come these grand schemes. So they decide they're going to build a house, or they're going to sell their house and go on a vacation. Not great planning, but, you know, something extreme like that. There's also what the DSM calls pleasurable but dangerous activities that the person will engage in during this time. And, you know, this can be things like a lot of sexual promiscuity or a lot of drug abuse. They feel like they're really hot and they're going on this hot streak with gambling or something. There isn't the sense of consequences in this. So having those two sides are part of what makes up bipolar disorder. Again, a mood disorder. Now, I want to keep in mind that when treating mood disorders, we need to remember that we're biological beings, so there's biological theories and treatments, but we're also thinking beings, so there's thought treatments as well. And I'm just going to kind of run through a few of those with you. There's some biological treatments, and we're just going to narrow in again because the topic is too large to look at biological and thinking treatments for depression and bipolar. So first off, let's think in terms of genetics. It's pretty clear that genetics are involved in mood disorders, especially in bipolar disorder. There is very strong evidence that bipolar disorder, and there's many studies to back this up, that this runs in a family history. So if one identical twin has bipolar disorder, for example, is over a 60% chance of the other of the twins having bipolar disorder. You contrast this with fraternal twins with bipolar disorder, and the rate's only 12%. So it's fairly clear that genetics play a huge role. The same thing is true that if you're related to somebody with bipolar, then you have a higher chance of experiencing bipolar within your life. With depression alone, major depression, there are probably versions of the disorder that have a stronger genetic component to them than others. In particular, what we call early onset depression. That is, when you have an early first experience of depression in childhood or early adolescence, that seems to have a stronger component to it. Also, triggered major life events of trauma can lead to experiences of depression later on. But that is where you get into that combination of a genetic predisposition and then what is called epigenetics, where genes are turned on or off based upon experience. That then can lead to depression. Now, in terms of neurochemistry, there's a number of neurotransmitters that are implicated in mood disorders, and the class of neurotransmitters that normally involved in this is called what is called monoamines. So there's things that we've talked about already in the class. So things like serotonin. But there's two other monoamines. One is called norepinephrine, and the other one is called dopamine. Dopamine, I'm sure you've recognized that as well, because that has to do with pleasure, the experience of pleasure. And the balance of serotonin, it seems, is a major factor in the experience of depression. Now, there's a number of brain areas that seem to be involved in mood disorders that give dysregulation or dysfunction, particularly in the prefrontal cortex, but it also seems that when there's this disruption in the serotonergic system, that your neurons just aren't as sensitive to the serotonin as maybe it should be. And of course, we've already talked about this as well. The amygdala is an area of the brain that is involved in processing of emotional information, and the amygdala seems to show overactive responses to emotional information in mood disordered individuals. And this is true for both bipolar and in depression. The hippocampus is an area of the brain that's very involved in memory and in concentration. And in people with chronic depression, you often see actual physical shrinkage of the hippocampus. And this obviously is going to relate to problems with concentration and attention. And then finally, there's the anterior cingulate. It's an area of the brain that's involved in a lot of different activities, but it's pertinent to mood disorders, particularly in responses to distress, to stress, and in sort of making choices of behaviors. And so we see that that's part of it as well. Now, when it comes to biological treatments, there's some good treatments for these disorders. In the 1950s and 60s, there was two older classes of what we call the monoamine oxidase inhibitors and tricyclic antidepressants. And the tricyclics are still used these days to some extent when other things don't work. And they're relatively effective. About 60% of people respond well to tricyclics, but they have a lot of side effects, and there's some dangers to it. Like, for example, if you eat cheese with some people, that can cause a fatal overdose. You know, there's all sorts of things that can go on wrong with it. But there's a lot safer drugs now that are extremely safe. And the drug that has really taken over the markets is what is called selective serotonin reuptake inhibitors, or SSRIs. And back in the 1980s, an SSRI by the name of Paxil or Prozac, those types of things came out onto the market and really kind of supplanted all the other ones. And even more recently, there's more designer drugs that have come out that are even safer and more effective. And they typically deal with looking at those other two monoamines, not just serotonin, but norepinephrine and dopamine as well. And so they're really good at helping the person's mood be lifted over time and get out of that depression. And then, of course, for the treatment of bipolar, lithium has been the drug of choice for a long time. It seems really to stabilize those mood swings by stabilizing a number of different neurotransmitters. But the lithium is problematic because there are some tremendous side effects, and can cause some gastrointestinal problems as well. So over a long period of time, the people have continued to look for other kinds of treatments. And so for bipolar disorder, sometimes antipsychotics are used as well in combination because it works a little bit better and mediates the side effects. And then finally, there are some psychosocial treatments. And I'll take a look at this more in depth next week. But I just want you to highlight something called the cognitive behavioral therapy, which really looks at helping people begin to look at the brighter side of life, essentially. We'll look at it in more depth later on, but by helping people look at the brighter side of life and engage in some positive activities in small steps, this can actually be as effective as treatment pharmacologically, say with Paxil or Prozac. So something to just keep in mind, that there are multiple components to mood disorders. And I think we'll stop there for today. You take care. Bye-bye.